This production was made possible through a grant from the Richard M. Fairbanks Foundation.
The United States has surprisingly high maternal and infant death rates compared to other developed countries. And compared to other states, Indiana ranks near the bottom. These tragic rates rise even more in African American and Black communities for Black women and babies. Hello, I'm Tony Gillespie, Vice President of Public Policy and Engagement with the Indiana Minority Health Coalition.
And I'm Lauren Davis, reporter for Side Effects Public Media, WFYI's health journalism initiative. Together, along with the Indianapolis Recorder, we wanted to bring this data into focus and see what solutions might exist to improve outcomes. Please join us in the next hour as we talk to experts and mothers from around Indiana to address these issues. We welcome two panels into WFYI studios to discuss this topic and answer questions from the community. The first conversation focused on pregnancy and birth, and the second on birth through the first year. Today, we would like to share some of those conversations with you. It has been edited to fit our WFYI time slot.
Panelists for Part 1, which took place in December of 2018, are all mothers themselves. They include Dr. Christina Box, State Health Commissioner for the Indiana State Department of Health, Bianca Wilson Gillespie, an advocate and volunteer doula in training, Dr. Indy Lane, OBGYN with Community Health Network, and Ashley Rainey, a registered nurse and clinical educator for labor and delivery. Our moderator was Oshia Boyd with the Indianapolis Recorder.
So let's start with a statistic. According to the United Health Foundation, which publishes America's health rankings, women here in Indiana die at twice the rate of the nation as a whole, before and immediately after birth, 21 to 42 per 100,000 births. And Black women's deaths are even greater. What is going on? Who wants to start?
Well, I'll be happy to start. As the State Health Commissioner, it's really depressing to see the statistics with infant mortality and also with regards to maternal mortality. We know that our nation as a whole, compared to other developed nations, has a significant issue with both of these factors. But when you look at Indiana, you start with women who have a higher incidence of smoking and higher incidence of obesity, which then leads to increased risk for high blood pressure and for diabetes. Those factors, risk factors, definitely increase a risk for a maternal death with pregnancy. Okay.
Well, let's keep unpacking the numbers. For Black women in Indiana, the rate is more than 53 deaths per 100,000 births, 2.5 times the national rate. Bianca, you're a mom. What goes through your mind when you hear a statistic like that?
It's pretty gut-wrenching, and just to piggyback off of Dr. Box, it just speaks to high blood pressure, the obesity rate amongst our African-American women in low-income areas, and it contributes to that, and something needs to be done definitely about it. Me being a doula in training, I'm dedicated to providing my services and educating as many women as I can to get those numbers down.
So can you tell me a little bit about what you do as a doula and what is the difference between a doula and a midwife?
A doula is a trained professional who provides emotional, physical, and informational support to a mother in labor. A midwife does those things in addition to prenatal care and actually delivering of the baby.
Okay. So it sounds like, from what I'm hearing, Dr. Box and Dr. Lane, and as well as you, Ashley, that a lot of things that are determined before a woman is even pregnant or kind of there in the pregnancy kind of comes out during the pregnancy. And so we need to be thinking about some things as far as health care before pregnancy. Is that what I'm hearing?
Absolutely. You know, preconception, a preconception visit, preconception care is essential so that you can have a conversation with your doctor. You can talk about ways to minimize some of these risks for complications in pregnancy. If you don't have that discussion until you are well beyond the first trimester, it's too late in some instances to intervene so that you can have a healthier pregnancy and a healthy baby. And so making sure our young women are attached to a primary care provider and then have connections with an OBGYN if they are planning pregnancy, is essential. We talk about, prenatal vitamins, and now we know that a baby aspirin or progesterone supplementation can also help women throughout their pregnancy have healthy babies. So those discussions occurring early on are essential.
Even as early as just having a visit with a women's care professional so that you can talk about planning your reproductive health, planning when you want to become a parent, so that we don't have as many unplanned pregnancies where people are very ambivalent about it. And actually, as Indy says, getting those health factors addressed, and even the socioeconomic factors that may be a barrier to them getting care or to be able to get into care and sustain that through their pregnancy and after.
I think it's really important that education starts in the community early on. We neglect to bring that to the school setting where our childbearing age young teens start sometimes early on creating families and having children. So if we can educate them on the importance of getting healthy, a proper diet, exercise, it can kind of help further the impact of things and decrease those morbidity factors and comorbidities that they're bringing into the pregnancy early on.
So you've kind of hit on something that I want to go back to, the prenatal care. So we have statistics from the state on prenatal care. About 72% of white women get prenatal care starting in the first trimester, but it's only 58% of black women. Our goal in the Healthy People 2020 plan is close to 80% for the state, right? How will we get there, since it will require raising access and utilization of resources by a huge degree? I mean, that's really 58% for black women, 72 I would think it would be higher.
So getting that access to care, depending on whether you're in a rural or an urban area, is really two different stories. We have 33 counties that either don't have a hospital or the hospital does not have obstetrical services. So being able to get care closer to home for those women, to get them into prenatal care, follow them through pregnancy, they still have to go to a different county to deliver, but at least we know that they're in care and getting all of these factors that we know are risk factors for maternal and fetal morbidity and mortality addressed. But when you look at our highest risk zip codes, of those 13 highest risk zip codes from our 2016 data, at least 7 of those are right here in Marion County. 1 is in Lake County and 1 is in Allen County. So those are areas where we know that there is care available. It's a question of not getting women connected to care early in pregnancy. And how are we going to connect them to care? How will they trust the healthcare provider? How will they know the resources that are available to them? So that's why the governor this year is supporting, as part of his agenda, our OB navigation program, which the purpose is to attach women to a community-based healthcare provider that actually will walk through the pregnancy with them and will address getting into prenatal care, will address things like the high blood pressure, the diabetes, and the other issues that we've talked about, substance use disorder or smoking in pregnancy, but also make sure that they help to remove those barriers to a woman getting into care and then sustaining that care through pregnancy and then getting the care for her child after delivery. And that could be someone like a nurse from the Nurse Family Partnerships, which has been very successful and is in 37 of our counties here in the state. It could be a community-based healthcare worker. It could be a doula that functions as a community health worker. It could be paramedicine in some of our counties where we don't have those same resources available.
Now, I want to make sure that when we're talking about mortality rates for specifically black women, that we don't just focus on the mothers who may be of a lower socioeconomic class, because when it comes to maternal mortality rates, it cuts across all socioeconomic classes for black women. Why is that? What is going on there?
For me, I think it's just those predisposed factors and bias that naturally everyone has. I remember being in school and reading in books, and it had, black women tend to not make much noise when they're in labor, or usually cry out when they're transitioning. It's just those type of things that you get from education that people
read that in the book?
Yes, I did. And you take that literal, and people apply that when it's not necessarily true. I mean, everyone copes with pain differently. So we have to sometimes put what we've learned to the side and look at the individual, not what literature says they should be responding and how they should be responding. So,
anyone else have any thoughts?
I think we have to have a better understanding of our cultural differences too. I think that doctors overall want to provide good care. I don't think they intentionally want to treat patients differently, but our unconscious bias sometimes takes over. Our training can influence how we treat patients. And so being aware of how we are different, how we receive information is important. And I think we can help doctors do that and still be authentic and still deliver good health care. But we need to recognize what we're missing, what we're not communicating to patients. And we need to help dispel some of the myths. You know, Ashley mentioned talking about contraception in school-based programs. And we know in states like California and Massachusetts where they have those programs, their maternal mortality rates are among the lowest. And so we need to dispel myths about the safety of contraception so that young girls are not getting pregnant and so they can, you know, focus on their education and not run the risk of having some of these complications. We need to talk to them about the importance of prenatal care and in all honesty, help them navigate the system in terms of what happens if you get pregnant and you don't have insurance so that you can present early. That should not be a barrier. The fact that you're uninsured should not prevent you from seeking the care that you need and you deserve.
So there's a memorable line from the first Indiana Jones movie when Indy was trying to recover from a physical battering. He says, "It's not the age, it's the miles," implying that wear, tear, stress play a big role in health. And that's kind of what mental health plays a big role in that. That was meant to be funny, but it's also true, apparently. Researcher Aline Geronimus confirmed the notion in her investigation of Black maternal and infant health. She called it weathering. And I'll quote, namely, that the health of African-American women may begin to deteriorate in early adulthood as a physical consequence of cumulative socioeconomic disadvantage. She also noted in a later study that weathering is associated with what she calls high-effort coping, and that applies across the socioeconomic spectrum. So your thoughts on that, because that does play into the mental health.
Well, I would say that one of the number one causes for infant mortality is preterm birth. And we know that preterm birth in women who have high stress level hormones on a regular basis is higher. So there's very good evidence out there, and I'm sure Indy could speak to this too, that indicate that women who are chronically under stress, chronically trying to figure out how to keep the lights turned on and food on the table, get transportation, you know, get their children to where they need to be or get to a job, that kind of stress leads to issues with the pregnancy itself. It increases our blood pressure, if nothing else, right? Which increases the risks associated with pregnancy.
And I think that just being a minority in America, you know, even if you have a very good situation financially, you always feel that people are making judgments about you, whether it's about your work ethic or about your social situation. And a lot of times in professional situations, you are still maybe the only female or the only Black female in that environment. And there's a stress associated with that, just being different and feeling as though you have to kind of go the extra mile to prove that you are worthy of being at the table. So I think that even if you are not in a low income area, if you're a professional, you're well educated, you still feel some of that stress, and maybe that's why we're seeing the same poor outcomes regardless of education or socioeconomic levels. I think certainly that plays a small role in it as well.
Well, and you kind of alluded to that earlier today when we were just chatting about kind of a microaggression that you encountered, and just how that plays a role just in your mental health wear and tear of just having to prove, like you said, prove yourself that you do belong here.
Right.
And that's a constant thing, and it is wear and tear. Do you have anything to add?
Yeah,
Ashley or
Dr. Lane and I had a discussion earlier where she in a report had made a comment about the lack of Black staffers in healthcare, and I totally agree. I've worked at 3 different hospitals, and at 2 of them, I was the only African American nurse, and at the other, out of like 200 employees, I was one of 5. And in itself, that's an issue because I, again, got to prove myself that I'm worthy of being here and I can give great care. But on the flip side, being the patient, from the viewpoint, you don't encounter the same race. So then you feel uncomfortable.
Exactly.
I got to be a certain way because I don't want them to have false pretense of who I am. So, but when you're able to be with your peer, there you do act and talk a different way. And you shouldn't have to, but you just don't feel comfortable at times outside, you know.
Well, that's what I was going to say. It brings a level of comfort.
Absolutely. To see someone with the same cultural background as you.
And understanding.
There's a sense of, you know, that you would feel comfortable when you see someone with the same cultural background.
Go anyone else?
I think you can be sensitive. You can be a part of a different race and still be sensitive and authentic. I think that we can't, you know, as Ashley and I talked about, you can't teach someone to be well versed in what goes on in Black culture or Latino culture like someone who grew up that way. But you can be sensitive to it, and you can be well educated about the differences and the cultural differences and how they view family or how they view childbirth and how they view the hospital system.
Okay.
Because a laboring woman, empathy doesn't require you to have the same cultural background. You know, and a woman in labor, that's the most vulnerable you could ever be is in that moment. And to have somebody who is empathizing with you, and you know, you're not looking at color, you're looking at, this is someone who is giving life. How can I provide the best service to her? Because your birth story, you know, I share my birth story with my children. You know, they know it. We talk it, I tell it every birthday. I share their birth story. So that's something, you want that to be a happy story. You want it to be memorable and just like, you know, you don't want it to bring back negative memories for you. Because what's the greatest thing we do as women, is bringing life into the world.
And it's probably one of the most 2 to 3, maybe 4 or 5 most important days of your life,
Yes.
right?
Yes.
And so even though it may become usual, you know, the same thing for us over and over, to every couple, that is a unique moment in their life that they will, for, as you say, ever remember.
Oh, definitely.
And our goal is to enhance that and make that as positive an experience as possible.
The Indiana General Assembly has passed 2 bills regarding the perinatal experience. One created the Maternal Mortality Review Committee, that's Senate Bill 142, and the other mandates establishment of credentialing based on level of care for birth centers, and that's Senate Bill 360. So from a policy standpoint, what else does Indiana need? And do you think this is enough?
I don't think it's ever enough, but what I will say is that they are both huge steps toward addressing maternal and fetal or infant morbidity and mortality. The levels of care basically is to ensure that a mom and a baby, whatever risk factors they have, that they deliver at the proper level of facility that can actually address not only with personnel but with equipment and technology those risk factors. And we know it's already been shown that levels of care in NICU has decreased infant mortality and morbidity significantly. It has been shown that those areas like Arizona and some other states that have done this for maternal mortality and maternal care has also decreased that. I think the maternal mortality review care, some people would say, well, it's kind of too late at that point, isn't it? But the reality is to go back and to dive deeply and to look exactly what factors led to us losing that mama and what could we have potentially changed, then allows us to go forward and to develop policies and programs or to give extra education at that particular facility or those particular individuals to make sure that we can then help the next person that comes along afterwards. And that has been also shown to decrease that incidence.
I think we need legislative support for postpartum care as well. Many women, whether they're privately insured or whether they have Medicaid, get one postpartum visit, generally around 6 weeks. And even the American College of OBGYN is saying now that women need to be seen. This is a continuum of care, that we should see women back as early as 3 weeks, then 6 weeks, and then even some women at 12 weeks to make sure that as they're going through this postpartum period, that they're not having new challenges that will affect their health. And when we look at maternal mortality, that's over a course of a year, you know, a death over a course of a year. And if a woman, one, only has insurance until she's six weeks postpartum, or only has had one visit, and maybe she didn't go to her visit because she had to go back to work in 4 weeks. So our postpartum care needs to be revamped, our education about your postpartum experience needs to be revamped, and we need support from insurers to allow doctors to see patients more frequently in the postpartum period and not feel as though they're going to be penalized financially.
I agree.
I think the standardization of care is really, really important. As we look at one of the #1 causes of mortality, postpartum hemorrhage, you will see a lot of hospitals are standardizing their approach. So implementing that CMQCC, which is that California Maternal Quality Collaboration, mouthful, approach of things where they have a risk assessment that every mom gets upon admission, and it's ongoing throughout her time, and it updates, giving us that warning from green being you're that lower risk, so you do your standard draw a typing screen and hold, to your yellow is a typing screen with a cross match, and then your red is the full blown. We have everything on standby, medications, everything ready to respond during that situation, to hypertension management, the standardization of how we have a mom who is preeclamptic or have some severe blood pressures, we treat her the same as any other mom. It helps to make care standard and approach that all of us are accustomed to no matter where we work, or if we chose to go to another facility, we're doing it the same across the board.
Something as simple as if a patient presents postpartum to the emergency room, making the obstetrician on call be called about that patient, because she may show up with high blood pressure and they think, oh, let's give you a little diuretic here, you probably have extra fluid and we'll send you home. But the reality is it may very well be postpartum preeclampsia, which may lead to seizures, which could lead to excessively high blood pressures and even strokes, and that morbidity that's associated with that. So it's really important, as Ashley's saying, to have those kind of standardized things within your hospital system and your clinic system to make sure that we continue to think of that patient in the postpartum period, and even for that first year, because postpartum cardiomyopathy frequently won't show up till later, where your heart doesn't function as well and you actually end up with issues with congestive heart failure.
Wow. I didn't realize that was a serious issue that women endure after having a baby. Because you kind of think you have your baby, you're fine. You're fine, you're done. You go 6 weeks and you everything, you get the all clear and you just...
But a third of those deaths are going to happen in the postpartum period. And I think that that's important for women to realize, that they are not out of the woods just because they've been discharged from the hospital. They have to be cognizant of the changes that are happening to them. If they are short of breath, that is not normal. That is not a function of being up with your baby. If they have a fever, that is not normal. They need to call their healthcare provider. And then when they do, as Dr. Box says, then when they do present to the ER, our staff need to recognize that, a fever in a postpartum patient may be a little different, or shortness of breath in a postpartum patient. It could represent preeclampsia. She could have fluid in her lungs. It's not pneumonia. It could be a pulmonary embolism. So we have to do a better job, again, in that postpartum period where we're seeing women die frequently.
Well, and educating women, because so many times, like you just said, you think you're tired, you're sleepy, you don't know, you just put it off, oh, this is because I haven't been sleeping very well, or my body's a little weird, but probably not a big deal. Not realizing that it really is a big deal. You need to go back and be seen immediately.
Right.
Well, one thing that I do know is a lot of hospitals have a lot of new graduate nurses. So they're still trying to learn. So sometimes they may not do a great job of educating a mom on the importance of understanding by, 2 weeks or so, you should be feeling back normal. And if you're not, feeling comfortable calling your physician and saying, hey, I'm not feeling well. A lot of times you will hear patients who wait for a long time to come in. They go, well, I didn't want to bother the doctor. Or it was the weekend. I knew it was a holiday. It doesn't matter. You still should be calling to be seen if you're not feeling like yourself within, 10 to 14 days or so.
That's good. That's a good tip to learn, to know.
Knowing your body and advocating for yourself are themes that continue into part 2, when the discussion turned to delivery and the days, weeks, and months following.
Our panelists continued the discussion, speaking about the importance of breastfeeding, educating fathers along with mothers, and again, weathering the idea that Black women's bodies reflect the stresses of racism and bias.
Panelists from this January 2019 panel were Dr. Virginia Kane, Director of Marion County Public Health Department, Kelly Breen, Program Director of Speak Life, Ryan Kareem, a breastfeeding coordinator with WIC, and Dr. Brownson Tucker Edmonds with the IU School of Medicine.
So, depending on the year and data source, Indiana ranks in the mid-40s out of 50 states. and the District of Columbia for maternal and infant mortality. Why?
I think it begins with the health of the mother and the communication between the healthcare system and the family. It's broken, and it's been broken for a long time, and that's why we're seeing the rates that we're seeing right now.
Okay. Anyone else have any ideas of what's going on?
So I think a lot has to do with social determinants. So we find that when we look at the data for infant mortality, the higher risks are in socioeconomic areas where there's a higher rate of poverty, and a lot that comes with increased poverty also comes with a lot of stress that's related to, I've got to figure out, wow, you know, I may not have transportation, so I got to get on our bus system, and here our transportation system is such that there may not be grocery stores where I live, so I have to get maybe my food at the 7-Eleven. And so I think all of those stresses are huge, and I know at least in Marion County, we've seen our poverty rates increase. And think about this, minimum wage has not increased in 10 years in this country, has not increased, but when you look at inflation, you know, what you got to pay for your rent, your utilities, and everything, I think those stresses can have some impact.
Okay. So I understand what you're saying, your point about the stresses and poverty, but as we look across all socioeconomic spectrums, though, it still tends to be a problem for African American mothers and babies. So how do we add that into the equation then? How do we kind of lower the infant and motherhood mortality when it comes across all spectrums?
I think that I agree with both of the other two panelists, and I think that, you know, we have to stop being afraid of racism, which is the reason for the systems being broken, which is the reason for increased poverty, particularly in the Black community, not having, you know, fresh food markets in the Black community. I think that we need a massive overhaul of the system. We have to destroy the systems that, you know, that have been put in place that prevent women from being in optimal health, that prevent, you know, families from having access to fresh foods, which ultimately leads to babies not having proper access to their first food, which is breast milk. And so I think racism is you know, we can't be afraid to say that out loud. That is the reason that Black women in Indiana and across the nation are dying at higher rates. That's the reason why our babies are dying at higher rates. It's not that there's anything inherently wrong with Black people. There's nothing wrong with us. There's something wrong with the systems in which we live.
Absolutely. I'd like to piggyback on what Ryan is saying. I agree wholeheartedly. And I think that a lot of that, too, is the implicit bias and the way things that are working within the systems as well. I think for a lot of moms, there's the fear of the healthcare provider. A lot of the moms that we work with as doulas, we're hearing them say things like, I don't know if I can trust my doctor, but if I say something, I don't know what's going to happen to me. And that's a big problem when you're trusting your life to someone and you're afraid of them. You know, so questions don't get asked or answered, and the issues that come up, they are swept under the rug until it's too late. And that's absolutely a huge problem.
So what she's implying a little bit is that too, what's the cultural competence of the provider that's taking care of the pregnant mom? And so I may be making recommendations to a mom, but it's so unrealistic related to my lifestyle. You know, as a patient, you're saying, well, wow, this provider doesn't even have a clue what's going on with me. So the recommendations that I'm making, that he's making, is just so far off the chart. I've got to be concerned about his other areas of his expertise in taking care of me during my pregnancy. Now that's one point, but she emphasizes another point, and that is, both my colleagues here, is that we have to look at our system.
Yes.
You know, we always blame the patient why their outcomes are not great, but just how great is our system? So, you know, we know that mothers who are on Medicaid insurance don't do as well as if you're on private insurance, but they're dependent upon the system that's provided to them. So I want to make my prenatal visit, and I'm primed and I'm ready to go. Taxi cab that's contracted by the system arrives 1 hour late after my appointment. I can't make it, okay? And I'm trying to make an appointment for my prenatal visit, and I may only have 1 hour in a day to make that appointment, and the line's always busy. Or I've called and I want an appointment with the doctor, but they're telling me, oh, it's going to be 6 weeks or 2 months away. So if I can't get in the first trimester, wow, I may have a poor adverse outcome.
What is the impact of weathering? The theory that stress, systemic racism ages Black women's bodies on prematurity and low birth weight. Is that something that you guys are familiar with? Do you think it actually does have an impact on Black women, their babies, their birth weights?
Absolutely. I think weathering has a lot to do with just the overall health of Black women, just by and large, but then where it comes to birth, pregnancy, and postpartum, when you talk about postpartum depression, add that to the systemic racism that she's been dealing with all of her life. That's huge. And then maybe not even having an advocate or someone to speak with or a way to release that pressure. We talk about socioeconomic factors and issues that happen in her neighborhood, lack of nutrition, living in a food desert. That just compacts and compiles, and it becomes more than what a lot of women can really bear, honestly, emotionally and physically.
And it will have an impact on the baby as well.
Absolutely.
Ryan, do you want to add something?
Oh, I was just thinking about, you said it would have an impact on the baby, and I think, you know, absolutely. There's a study that was done in terms of postpartum depression, and moms were communicating with their babies, talking, laughing, and the baby was, you know, babies coo back and they talk back, they participate, and then they had the mom go back in the room with a stoic face. No matter what the baby did, she was supposed to have a flat affect, and the babies were like distraught. They didn't understand their mom. It was like she was a vacant vessel, and that is like a prime depiction of what postpartum depression does. And so you think about the economic factors and the social determinants of health and postpartum depression and all these extrinsic factors. We haven't even started to talk about physiological issues and medical issues that mom may be experiencing. And so yes, weathering, it definitely plays a role. It definitely could impact, we know that stress can cause a mom to go into early labor, preterm labor. And we also need to be very, very aware that postpartum depression is, a lot of times it's not just postpartum. I think we need to think more broadly and think about perinatal depression. A lot of times moms need to be screened for depression in pregnancy because a lot of moms are depressed because of all the things that we have talked about in pregnancy. And so I think that, better support for moms.
We'll talk about support. I want to bring in the dads.
Yes.
Because we want to talk about the dads.
Yes.
So what roles? Can I just put one thing out there? Because one of the things that really, it hurts my heart, I will just say that, is the number of folks who are, who discontinue, people who are taking medication. I know that there's taboos in our community about medications for mental illness. There's taboos about mental illness, and there's taboos about medication for mental illness. But to see people who are actually in care on medications for various mental illnesses that are stable on those medications, and then they find out that they're pregnant and they stop everything cold. And then to have to try to really reassure them that they can take, what I try to just, if I can message one thing to women, and the reason I interrupted you is that you have to be well. There's actually reams of data to support the fact that if your mental health is not optimized to the extent that it can be, that it will have negative implications and impacts on your newborn, let alone on you. And so I really encourage women, particularly if they're already, it's one thing to have a conversation about beginning medications, which is also can be safe in pregnancy, but I understand people's reluctance. But if you are on a regimen that is working for you and keeping you functional, that it is so important to talk about whether there's anything that needs to be changed for pregnancy. That can be something that needs to happen. But I think that I just get, and there are doctors out there who just, positive pregnancy tests, stop all your meds. And it's like, that is not the right answer. Absolutely, if you're not comfortable with it, consultation, get them in quick and early so that you can have those conversations. But women need to be well if their pregnancies are going to be healthy and if their children are going to fare well.
Well, I think this is still where dads come in at.
It is.
Yes.
Go ahead, Dr. King, you have something to add?
The stress also, because I'm an infectious disease doc, the stress also causes increased inflammation.
Yeah.
And if you have this inflammation going on for a long time, boy, does that impact negatively all your different organs in your body, the inflammation. So it's like those hormones are changing, and it increases the inflammation. So you can only go through that inflammation for just so long without causing significant wear and tear on your body.
Yes.
So when it comes to the dads, though, I got to bring the dads in. We don't want to leave out the dads because they are very important in this equation. Because a lot of times the dads are seeing what's going on. The dads see the mom under stress, under duress. The dads see the mom struggling with the baby. The dads see the baby struggling. So what role do dads play? How can dads support? Because we know dads aren't delivering the babies, but they're still there. They see the distress on the mom's face.
Listen, some of these dads are in distress themselves as a result of seeing all of this.
Yes, and they don't know what to do.
There's starting to be more conversation about paternal depression.
Oh, that's a thing?
Yeah.
One of my colleagues recently just published some work around paternal depression. It's a real phenomenon. We were just working on a review looking at dad's contributions to perinatal decision making, and largely the research that's been done. It's not a ton of studies that have really been done at this, but a lot of the work that's been done just shows that our systems of care, our obstetrical systems of care, are really, I think on one level they're rightly women-centered because that's sort of a point of pride and a point of focus for women's health providers. But I think that we miss sometimes that to the extent that the woman desires for their partner to be involved and engaged, and that person is a source of support, that's actually an important aspect for us to be inclusive of as well. And most of what's been reported out in the work that has been done suggests that dads feel pretty marginalized and pretty sort of cast aside in the obstetrical care space. And I will admit, in my own training, that I was almost in my 4th year of residency before I realized what an afterthought, dads were in the care I provided.
Well, yeah. So, it's so important for the dads to be part of the prenatal visit, seeing what's on the sonogram and watching what's going on. And they have a calming effect on their significant other.
They release that oxytocin.
Yes, exactly. Thank you. But the other thing is important, and this comes with breastfeeding. It's so important. A lot of the mothers look to see how their partners view breastfeeding, and it impacts sometimes their ability whether they're going to breastfeed or not.
I was actually going to say that the Indiana Black Breastfeeding Coalition did a poll of mothers, and to really my surprise, I thought most moms would say that their mom would be their biggest supporter, or the person they look to for the most support. But in fact, it was dad. Over 60% of the moms said that dad was their biggest support. They looked to dad for support for breastfeeding. And I think that this is an area, the fatherhood engagement is really an area where I think the Indiana Black Breastfeeding Coalition and WIC is getting it right. I think WIC has even gone a step beyond just including dads in education and talking to dads, inviting them to appointments. We actually have a fatherhood engagement specialist who's a dad himself. And so it's like for dads by dads. And so it really reaches fathers, because it's one thing for us as a woman to say, come on, dad, come on back to this appointment. Let's talk dad stuff. We don't know anything about dad stuff, right?
So Dr. Walter Laughlin has this wonderful fatherhood program that we're really trying to do a great job of doing more education to really encourage fathers to participate. So it's just huge. And we give out what we call, I don't want to let you know how old I am, but in the old days, they'll give out coupons. So if you make a prenatal visit, it's our BABE program, you get so many coupons or whatever. So we give extra coupons. If the father's involved, you get double the coupons because they are key critical person as part of their pregnancy.
We know as doulas, we talk and we laugh about it, but we know that sometimes when certain people come into the birthing room, things will happen with mom chemically and as a matter of fact, physically. So if a mom tells me that she doesn't want mother-in-law there, and she really doesn't want mother-in-law there, the sound of her voice sometimes can slow labor down.
Really?
So sometimes just her presence and knowing that she has arrived at the hospital when she wasn't supposed to, that can shut mom down. We have that fight or flight system within us, and it works. Having dad there, having this man there who you feel comfortable with, that you love, that can change everything. Having that support, knowing that you have that advocate there with you, and she's going home with him. So strengthening that bond, there's no better time than birth and postpartum to let's do this together, let's be a team. And then he's that advocate as well, so it means a lot to have dad there. Absolutely.
Well, so breastfeeding was brought up. And actually, you guys are on it because we were going to breastfeeding next. So Side Effects Recorder collaborated on a story about breastfeeding in the Black community in 2017. That report cited a study by the Centers for Disease Control and Prevention. It said that hospitals in zip codes with more than 12.2% Black residents were less likely than hospitals in zip codes with fewer Black residents to endorse breastfeeding. Comments. And we're going to stay here for a little bit, so we got a lot to talk about breastfeeding. I know, Dr. Kane, that's one of your big things. So, so any comments about this study?
Well, I will tell you that when you look at breastfeeding, the Hispanic mother has the highest breastfeeding rates compared to their white counterparts, and African American women are the lowest in terms of breastfeeding, in terms of the percentage who breastfeed. And what I will tell you is that there are a number of factors I think that's related to it. It's one, do you have family support and encouragement to do breastfeed by your significant other or your parents or whatever. So I think that's key. But also I think sometimes it may also be related to your job. So if you, we find that a number of employers, especially if you're in a low economic job, position, that the employers don't encourage that in their setting, or you need to take time to do the pumping of your breast milk. So they don't encourage it, and so it's it's in a setting where you know, people may be commenting or teasing you and blah blah blah. So they don't. It doesn't happen, and it also maybe you've got two jobs and just the logistics of trying to get things done may not happen. So we've got a lot of work to do because half the battle, we know that if you breastfeed, it's definitely going to cut down on respiratory infections for your baby significantly. We definitely know it's going to cut down on your child being at higher risks for obesity. It's got so many positive things, and just the nutritional value alone, that brain development, I can't tell you how critical that is related to breastfeeding.
Yeah, there are lifelong benefits for sure. I think that a lot of women, I feel, particularly in the Black community, so kind of piggybacking on what Dr. Kane said, I think a big factor is support in the family. I also think that going back to work, we know that in this country we hardly have any maternity leave. A lot of, you know, and I recognize my own privilege in the fact that I was able to stay home. I had a maternity leave when I had my children. A lot of the women that I serve don't. And that was one of the biggest lessons I had to learn. When I started doing this work, I talked to a mom and she'd be like, yeah, I need a pump. I'm like, well, why? Your baby's 2 weeks old. And she's like, well, I'm going back to work. And I'm like, oh, girl, please, you need to sit down. You know, like the old schools, you know, your body needs to heal. You can't go back to work. And so one of the biggest, she, you know, she doesn't have leave. She doesn't have, you know, she's really behind now because she's taking these 2 weeks off. And if she was going into preterm labor, maybe she had some time off before, on top of all the appointments when she was pregnant, you know, that adds up. And so she's got to go back to work, you know, feet hitting the ground. And so I think that a lot of moms think that breastfeeding has to be all or nothing. And we know that that's completely not true. I think that, again, another hard lesson I had to learn as a supporter of breastfeeding is that we always want to push exclusive breastfeeding, only breast milk. And of course, we know that there are benefits. All the research says, you know, breast milk for 6 months is all a baby needs. However, any breast milk is better than no breast milk at all. And I think that we need to start pushing, having more conversations with moms about offering breast milk at all, even if she can, you know, if she needs to supplement a little bit, hey, that's fine. Breastfeed at home when you come, you know, home in the evening. You know, speaking to the, you know, having a place to pump at work. In Indiana, we have a law that says that not only that moms have a right to breastfeed anywhere they have a right to be, but any employer that employs more than 20 employees, they have to provide moms with a space to pump and a safe place to keep her breast milk. But a lot of employers get tricky about that, and so they might have a place to pump. You know, if a mom works on a factory line, sure, they have a place to pump, but it's all the way up in the offices where the people who sit behind a desk are, and it might take her entire break time to walk up there to pump. Or because she leaves the line to pump, the line has to stop. There's nobody to step in to take her place, and I think that we need to do a much better job in the nation and definitely in our state about really supporting moms in the workplace and giving them more options in terms of how they feed their baby. Breastfeeding doesn't have to be all or nothing.
I think to add to that, we have to look at the stigma surrounding breastfeeding for Black women.
Oh, yeah.
Because we know historically we were nursemaids, and the pictures of the slaves nursing white babies, and that gets burned into our brains and we see it, and it became, after a while, it was like, oh, I have money, I don't have to do that. So now I bottle feed, and it became this thing where, you know, you had money or you had status, you didn't have to breastfeed. And we need to remove that stigma as a community, as Black women together, but we also need to see more pictures of Black women nursing. When you see a beautiful pamphlet, or you see a picture or a poster, it's a white woman who's nursing, and it's this beautiful, this image. But if you Google Black woman nursing, dear God.
Yeah.
You know, and if you go to, right, and if you go to clinics and doctors' offices, the images that you see, they're not relevant to us, and they don't encourage us as Black women to be proud to breastfeed and to really see it as natural and beautiful for what it is. You know?
And there's sort of also, I mean, I think there's so much culturally that's packed into it, because, you know, the other piece is sort of the hypersexualization of Black women and the Black female body. And so this idea of like what it means to have sort of a culture that embraces sort of, you know, exposure in that way, you know, as opposed to like chastising it or shutting it down, you know, there's a lot of messages that say that like, that's not okay, when in fact that, you know, how do we reframe that to be that's beautiful, that's like, you know, life-giving, that's, you know, but we have, you know, there's just been so much that's really been put on us that's not even really about us that, you know, has kind of twisted the depiction and of what's sort of healthy
and sadly,
about
we've
our
absorbed
bodies.
it as well.
Yeah, exactly.
We take it on just naturally, sadly enough.
So Ryan, you mentioned 6 months of breastfeeding. That seems like it's like a magic number. The Indiana State Department of Health included an interesting fact in its 2016 report on infant mortality. If 90% of U.S. families comply with medical recommendations to breastfeed exclusively for 6 months, the United States would save $13 billion per year and prevent an excess of 911 deaths. That's astonishing. Now, I know you talked about if you can't do it exclusively, but do it here and there. But what is it in that 6 months? If you breastfed exclusively, why is that so important that it yields such extraordinary benefits?
When the baby is first born, their digestive system is not completely developed. And so I liken it to, ironically enough, is what I tell my moms, the Pepto-Bismol commercial, okay? So you've seen upset stomach diarrhea, right? They show the person who's got diarrhea, they drink the Pepto, and it goes and it coats the stomach lining to help to strengthen it, to make them not feel so queasy. And that's exactly what colostrum does, which is the first breast milk. That's exactly what it does for our babies. It goes and it coats the digestive system, plugging in all those little holes to protect the baby from getting sick. And every time baby gets breast milk, we get a new layer of protection. And it's not until the baby's 6 months old that the digestive system is completely healed. That's just one protective factor. Of course, we know that when we breastfeed, we're holding our babies. Breastfed babies get a lot more interaction with mom. A mom who's breastfeeding, she's looking down at her baby, she's talking to the baby, baby's engaged in conversation with just other adults, so there's a lot of brain development happening. If you've ever seen somebody bottle feed a baby, typically the bottle's hanging out, maybe if they're holding the baby, right? Sometimes we prop babies up, which is we shouldn't be doing, but if we're holding the baby's kind of looking that way, you're holding the baby, you're holding the bottle, you're looking around, you're doing other things, you are not engaging with the baby. And so bottle-fed babies don't get as much brain stimulation or brain development as as breastfed babies do. So, I mean, there's endless list of reasons why 6 months is a really magical number for breastfeeding, until exclusively breastfeeding for 6 months. Those are just two really good benefits of it.
And also, infants, their own immune system actually sort of kicks in around that 6 month in terms of developing its own antibodies and things like that. So there's also sort of a protective mechanism in that regard. Yes. So, like, yeah, there's many factors and variables.
Where can moms get support during that 6 months? After they left the hospital and they're still trying to breastfeed, but maybe they're having some issues, or things aren't going quite the way they planned. So where can they get support in that 6 months time period to keep them encouraged?
I'll repeat, doulas.
And lactation consultants.
Yeah, lactation consultants.
Absolutely.
WIC is a wonderful resource for breastfeeding. Every WIC office in the state of Indiana has breastfeeding support, so moms can certainly go to WIC. The Indiana Black Breastfeeding Coalition is a resource. There are lots of resources embedded into communities, and I think providers, of course, community-based organizations need to do a good job or a better job of letting providers know that they're available, and providers need to do a better job of referring moms, hospitals. There should be a bridge to gap hospital to home. There's no, day 3 is the day that most moms quit breastfeeding, right? That's when your mature milk comes in, your breasts are huge, they're hot, your baby all of a sudden doesn't know how to latch, even though breastfeeding was going beautifully in the hospital, right? All of a sudden you don't have all the extra hands to help you get things together. And so there should be a bridge to that gap so that moms know when they go home on day 3, day 5, when they're really struggling to make things work, they should have support already in place. Moms shouldn't have to get on Dr. Google to figure things out. They shouldn't have to be looking up resources. There should already be something in place. And a lot of times there's something available. Moms just don't know where to find the support.
Yeah. Dr. Kane.
Oh, I'm good. We can always, a lot of health departments have resources too, and we have a WIC program, we have breastfeeding support and training available. So I just really think it's just really critical, but I do think we have to devote a lot of attention, not just educating the mom about the importance of breastfeeding. We equally have to do a great job with the partner.
Yes.
And the care provider as well.
And the care provider.
We've had moms who have, right after labor, having maybe a C-section, been given meds that were contraindicated for breastfeeding. So baby's not nursing as well.
Wow.
And we're trying to figure out why baby's becoming failure to thrive. Well, she never should have had this medicine if she's going to be breastfeeding. She didn't know. Doc either didn't know or didn't pay attention to the fact that she was breastfeeding. So then we've got this child who was beginning to suffer when it was simply a matter of changing the med. So healthcare providers need to be educated and be held accountable for what's going on with breastfeeding with these moms.
When we asked panelists their final thoughts, the theme was clear: educate, advocate, and come together on all levels to create healthier communities.
To hear these conversations in full and to read reporting on these issues, please visit sideeffectspublicmedia.org. For Side Effects, I'm Lauren Bavis.
And I'm Tony Gillespie, Vice President of Public Policy and Engagement with Indiana Minority Health Coalition. Thank you so much for joining us, and thank you in joining us in our effort to decrease infant mortality.
This production was made possible through a grant from the Richard M. Fairbanks Foundation.